You know, my wife is a clinical social worker. And so the inspiration for this talk, the title came, you know, a little bit from, we could all use a little talk therapy, I think, right now, around the implementation of the Affordable Care Act. Let me just start by recognizing a few special friends who are in the room who've just been so important and helpful to me. George Thibault from the Macy Foundation, Jim Talon, who was my role model when I was a member of the Massachusetts House of Representatives, and Dan Fox, who has just been such an important influence and figure in my life for so many years. So, and so many others. Thank you for being here tonight, and thank you for having me. So I'd just like to start with recognizing something that I don't think people are sufficiently recognizing, which is what a monumentally important day January 1st, 2014 will be. We saw the signing of the Patient Protection and Affordable Care Act on March 23rd, 2010. And I think arguably the most important date in the history of this law, one could argue, is either that day or January 1st, 2014. On January 1st, we see a series of changes that will fundamentally reform the way healthcare works in the United States. And when we get past January 1st, there's really no opportunity beyond then to simply go back to what was before the passage of the ACA. So on January 1st, we see fundamental insurance market reform in all 50 states, not just the 6 states that have already done guaranteed issue, but medical underwriting for the writing of health insurance and pre-existing condition exclusions become illegal in all 50 states. Minimum essential benefits apply to all individual policies. Lifetime coverage limits are completely eradicated from health insurance markets. The individual responsibility provision or the mandate takes effect. The private coverage subsidies through the exchanges begin to flow, and people are actually covered beginning on January 1st. And similarly, the Medicaid expansions in the participating states take hold. These are all happening on January 1st. I don't think that there is a single day, perhaps with the day that Medicare started, that one could actually look at and hold up in comparison. And certainly in the history of the implementation of the ACA, this is the singular most important date. It's about 30 days from now. And when we get past January 1st, I don't believe there is any opportunity to go backwards. So I think looking forward to 30 days to this monumental bridge that we will be crossing on January 1st, it's time to take a little bit look back and reflect where we've come and to look ahead. And so I did while I was here in New York after I left the Senate and spent the rest of 2010 at Hunter College. Thank you, Hunter College. It was a wonderful experience. And Jennifer Rabb. I did while I was there at the Roosevelt House, I wrote a book, Inside National Health Reform. I'm surprised 2 years later it's still relevant. It still matters. But I did at the end of it put together what I considered to be the 5 important conclusions in my study and working on the law, both looking backward at the process and how we got to the point of passage, and then looking ahead to implementation and beyond. And so I thought I would use as the organizing frame for this talk tonight, looking back at those 10 conclusions, 5 looking backward, 5 looking ahead, and using that as both a way to sort of to organize and structure my comments, which I'll try to make as brief as possible, and then we can engage in discussion and conversation because people always have so much to say about this law. So let's start out with my first conclusion, which is the Affordable Care Act is a landmark in U.S. health reform and a landmark in U.S. social policy. It really, in the history of social welfare policy, has only 2 peers: Social Security, 1935, and the 1965 law creating Medicare and Medicaid. The ACA is really our only example of comprehensive health reform ever attempted and achieved at the national level. And I use it in terms of comprehensive reform by saying that it references quality, access, and cost control at the same time. The 1965 law creating Medicare and Medicaid created health insurance coverage for senior citizens through Medicare, and health insurance coverage for low-income families on public assistance, and didn't do anything particularly around quality or cost control. And so I think that it's worth recognizing the significance in terms of the breadth and the scope and the ambition of the ACA. The other thing, and I'll mention some more about this a little later, is that initial passage of a law is only the start. It's the conclusion of the legislative process, and then it is the start of a whole new process of implementation and continual revisiting and reform and revising that goes on and on. We are still revising and fixing Social Security since 1935, similarly very much with Medicare and Medicaid. But I'll talk a little bit more about that. My second conclusion was I thought that the process leading to passage of the ACA reflected the view that health reform is about values. People think of it as about money. People think about it as politics. People think about it as partisan competition. Fundamentally, health reform is about our values. Deborah Stone, who's one of my favorite political science writers, talks about how much of the policy process involves debates about values masquerading as debates about numbers and facts. If you ever turn on C-SPAN and you watch the debates in the Senate or the House of Representatives, and you see how the members are constantly hurling data, numbers, facts, factoid at each other, as if they could just figure out the right data point to fling at the other side, that the other side would say, oh my God, you're right, we're wrong, how could we have been so confused? We will now switch sides. And of course that never happens, because fundamentally it's not about numbers or facts or data. It's fundamentally about values and what it is that's important to us. And the ACA has a core value at its heart and soul, I believe, which is that we should no longer be the only advanced nation, the only OECD nation that allows our fellow citizens to suffer financial ruin because they or a family member gets sick. And that is still the policy in the United States going up until December 31st of this year. It changes after January 1st. It's not just the advanced nations. We now see that many of the middle-income nations and the less well-off nations, including Mexico, South Korea, Taiwan, Thailand, Turkey, and many others, have all leaped ahead of us and provide some form of basic health security for all of their citizens. At the Harvard School of Public Health this past fall, we had the former health minister of Turkey, who's really the George Washington of health reform in Turkey, who revolutionized that system and did create, in fact, real and meaningful universal coverage for all those citizens. Our dean at the School of Public Health, Julio Frank, did it in Mexico in this past decade. Other nations, far less well-off than we are, have leapfrogged ahead of us, and we are finally catching up. We only, though, when we talk about values, we only really appreciate and understand what our values are when they come into conflict with each other. We can all easily agree on a bland and wide list of values that we all say, yes, we agree with that, we agree with that. But when they come into conflict, that's when you know what we really value and we really don't. So we all say we like to keep taxes low and avoid having government get too big. And we also agree that everybody ought to have some form of health security. Most people can easily embrace those two values. They only mean it's something when they come into conflict, and you have to choose, and you have to pick a side. And in this case, American society picked a side, and we're moving forward. But it's not without consternation, which is why I concluded the next conclusion was that the achievement of health reform in 2010, we should not kid ourselves, was the achievement of a movement. And many of us refer to it as the health justice movement. Over 100 years in the making. Many wins, many losses, far more losses than wins if we think back to some of the signal years, 1949, Harry Truman, 1965, the creation of Medicare and Medicaid, 1974, when Richard Nixon's health reform plan, which is probably the most progressive plan that we saw in modern history after the 65 win fell because of Watergate, 1979, 88, 89 when we passed Medicare catastrophic and then repealed it the following year, 93, 94, the Clinton Health Reform Plan. Like any movement, it has its ups, it has its downs, it has sharp and fierce disagreements among the people who consider themselves part of that movement, and there's no controlling legal authority to a movement. It takes its own shape, it moves forward, it advances, it collapses. But clearly what was achieved with the Affordable Care Act was the achievement of a movement. And one thing that a good movement does, and a smart and effective movement, is it does some disciplined learning from prior failures. And I can say, as somebody who was in the US Senate in 2008 through 2010, that there was a tremendous amount of constant looking back to not just 93, 94, but the prior health reform eras and epochs, and understanding the lessons of those failures and applying them. Just to give you one example, if you like what you have, you can keep it. That was a direct lesson from 93, 94. It was the interpretation of the Clinton failure was that by telling everybody that everybody's coverage was going to change, hopefully for the better, we set ourselves up in 93, 94 for the defeat when the opponents to reform used that promise of change for everyone to scare people and significantly undermine reform. So there is learning, even in an amorphous, with no controlling legal authority. Bipartisanship was seriously pursued by not everybody, but by a few important influential leaders on both sides, and was simply not possible in the environment in which we faced in 2009 and 2010. I like to refer to 2007 and 8 as the era of health reform good feeling. Everybody wanted reform. We had so many stakeholders, hospitals, physicians, pharmaceutical companies, medical device makers, insurers, business groups, labor groups, come to Capitol Hill and tell us, you must do health reform. And by the way, they would wag their finger at us and they would say, and by the way, don't you dare do what they did in Massachusetts, which is just do access and not deal with cost and not deal with quality. You must do comprehensive reform. You must deal with all three. This is an historic opportunity. Don't you dare blow it. And everybody, and there were many, many bipartisan exercises. The launch of health reform in June, which I date to June of 2008, when the chair of Senate Finance, Max Baucus, and his ranking member, Chuck Grassley, co-sponsored the launch conference, launching of the health reform process. 5 months before the presidential election happened, it was already moving forward and getting underway. And it involved significant numbers of members from both parties. Inside Team Kennedy, on which I worked, there was a mantra all the time: this will never happen, never, ever happen. Health reform will be impossible unless it's bipartisan. And then in the spring of 2009, we had some surprising developments. Democrats won more seats in the Senate in 2008 than predicted, but not enough to do it alone. They had 58 votes. And then, surprisingly, at the end of April 2009, Senator Arlen Specter from Pennsylvania switched parties from Republican to Democrat, bringing the total up to 59. And then in June, Al Franken from Minnesota took his seat, and that created a 60-vote margin, and health reform was possible. During the period of time when that happened, the era of good feeling came to a halt when actual bills started being advanced and put forward and put on the table. And rather than talking about general principles, we were now talking about real policy change. And people began to move to respective corners. But the serious split came in August of 2009 with the Tea Party town meetings that were held across the country. And the impact of those Tea Party meetings was far less on Democrats, far more significantly on Republican members. And I use Senator Grassley as a leading example. Here are 2 quotes from Senator Grassley referring to the individual mandate, which was a Republican idea from the Heritage Foundation and other conservative corners going back to the late 1980s was their alternative to Clinton reform in 93, 94. Here's Senator Grassley in June of 2009, quote, "When it comes to states requiring it for automobile insurance, then the principle ought to lie the same way for health insurance, because everybody has some health insurance costs, and if you aren't insured, there's no free lunch." That was in June. In September, he was, these were both quotes from Fox News, by the way. His appearance, his verbatim words. He said, "Individuals should maintain the freedom to choose whether to purchase health insurance coverage or not." So the question is, what happened in that summer? And what happened in that summer was the Tea Party town meetings, where he was particularly targeted across Iowa. He held about 30 to 40 town meetings that month in Iowa, and in every one of them he was swarmed by the new Tea Party movements who had targeted health reform as their cause to cut their teeth and to show their impact. So this is what happened. Health reform became heavily polarized in that month, and by September, all Republicans who were still on the side of trying to achieve health reform looked for some way to escape and to get to the other side and to be simply on the opposition. And so by the time October came, there was only one member of Congress left on the Republican side who was supporting it, and she was tentative, and that was Olympia Snowe. And by early December, she flipped to the opposition. The next conclusion, looking backward, compromises and deals were necessary and not scandalous. When people looked at the compromises, they looked at things like what was known as the Cornhusker kickback, a particular Medicare deal for then Senator Ben Nelson from Nebraska, something that was called the Louisiana Purchase, that was a gift or a concession or an agreement made with Senator Landrieu, again, involving Medicaid, and the state of Louisiana. The Nebraska provision was removed. The Louisiana provision stayed in. But there were other things that were added in that process as well, and I include some of these from some of the members who sought some kinds of important programmatic initiatives that were important to them. A mandated coverage for clinical trials, the Indian Healthcare Improvement Act, which had been languishing for more than a decade, the National Office for Minority Health getting codified. Many of these were done. These were compromises and deals on the path to achieving the 60 votes necessary to win the Affordable Care Act. Many of these are now being implemented in ways that are quite beneficial to the groups. So let's stop looking backward and let's look ahead. And again, look ahead as I looked ahead in the fall of 2010 when I put this book together with some of my conclusions. So like Social Security and Medicare, the ACA will be revisited and revised repeatedly for years to come. The passage of a major law is by no means the end. These are not written in stone. These are written on paper, and they get repeatedly visited by Congress and changed. I constantly remind people when it comes to Social Security, which many people regard as the high water mark of U.S. social welfare policy, that when the original law was signed by President Roosevelt in 1935, the actual text of Social Security excluded from any benefits all agricultural workers, all domestic workers, all hospital workers, all government workers, all workers in firms with fewer than 10 employees, on and on, a series of those kinds of exclusions, such that about 2/3 of working African Americans and more than half of working women enjoyed no benefits from the original Social Security Act. And it wasn't until 1939 that Congress started the work of filling in those holes and those gaps. And it wasn't really until the 1950s that we really had the Social Security law that we know today. Similarly with Medicare and Medicaid, those laws get revised every year by Congress, mostly in ways that most of the American public doesn't like, sometimes doesn't know, and many, many times in much more significant ways, sometimes in ways that people actually notice, like the creation in 2003 for the first time of an outpatient prescription drug benefit in the Medicare program known as Part D. So believe it or not, there have been, in spite of the partisan polarization, by my count, 8 significant changes to the Affordable Care Act that have already become law in one way or another. Most of them I don't think are that terrific. They are part of the political compromise necessary for Congress to do its work. Some of the more significant ones, down near the bottom, an entire one of the 10 titles of the law, Title 8, known as CLASS, or Community Living Assistance Services and Supports, which was the personal priority of my late boss, Senator Edward Kennedy, to create a new voluntary disability assistance program for Americans who are temporarily or permanently disabled, was entirely repealed in toto rather than fixed this past January 1st. Similarly, we've seen significant cuts to the Prevention Trust Fund, which has been providing important support for community-based prevention efforts since the signing of the law. Funding for community health centers. They haven't been eliminated, they've been significantly cut back. Free choice vouchers, which was engineered by Senator Wyden, was eliminated completely. And of course, the major change, more than anything perhaps, wasn't done through Congress, it was done by the US Supreme Court in their June 2012 decision when they chose to make the Medicaid expansion in Title II of the law an option for states rather than a requirement. As it was originally written, the law was designed to provide Medicaid coverage to all low-income uninsured, and because of the Supreme Court decision, it will now be an option to states. That's probably the most significant change. By the way, I can find, I'm an inveterate optimist. I'm kind of like, you know, that kid's toy with the clown with the round bottom and you push it over and it bounces back up. That's me. I can find a silver lining around any cloud that you have. And so I can find a silver lining around this Medicaid cloud. And that is that it has just been extraordinarily compelling to watch Republican governors and Republican legislators one by one come to the realization that the Medicaid expansion actually makes sense. Particularly Governors Jan Brewer of Arizona, Governor Rick Scott from Florida, who wasn't able to convince his legislature, but went significantly out on the limb to embrace the Medicaid expansion after spending a large part of his own fortune trying to kill health reform before it ever got enacted into law. So we are seeing now a different kind of dialogue. We know that if the ACA had stayed in its original form in Title II, all of these about 9 or 10 Republican governors who've embraced the expansion would be criticizing the dictatorial move of the federal government to impose this on states. We now have a significant group who are publicly embracing this law. During the government shutdown, Governor Brewer of Arizona actually said to the media that if Congress succeeded at this point in defunding Obama, it would cause catastrophic budget damage to the state of Arizona. So there are things that are changing. I would believe, I remind people that when the Medicaid program was created in 1965, it was an option for states. It wasn't until the early 1970s that just about all states were part of it, and the last state to join Medicaid was Arizona, not until 1982. Similarly, when the Children's Health Insurance Program was created in 1997, many states initially said, we won't go near this. Within 5 years, all states were part of it. The financial incentives for states as part of the ACA's Medicaid expansion are so compelling compared to the traditional reimbursement states receive that I would predict with, I think, a good degree of confidence, within 5 years, I believe that all states will actually be part of this once we get over the partisan furor around Obamacare. So many more changes will come. I hope, by the way, you know, there are many parts of the law that should be revisited right now. I'll just hold up one example. There's one part of Title III which creates Medicare penalties on hospitals with high rates of readmissions. We know that this is actually having a significant and we believe positive impact on hospitals because we are seeing some significant declines in the rates of readmissions since this provision has gone into effect more than a year ago now. At the same time, we know a lot more now than we knew when we wrote these provisions in 2009 and 2010. And we know that it has many unintended consequences, and we know that if we were writing that today, it would look significantly different than it does. Congress needs the ability to come together in a bipartisan manner and look at this provision and so many other provisions like it and begin to make adjustments, changes, modifications that they have thus far been unable to do because of the intensely partisan atmosphere in Congress on it. And my hope is perhaps beginning in 2014, more likely beginning in 2015 after the midterm elections. Some pessimists say maybe not until 2017. Congress will be able to get down to the essential oversight work to try to bring these provisions up to date and make them work. There's a long list of things that need to be addressed to make this more effective. No law is ever written in stone, and the ACA certainly is not. Next conclusion, looking forward, affordability for enrollees. This is a key test. It's a key test, short-term, medium-term, and long-term. And I'll just hold up the example of Massachusetts. The Massachusetts health reform law passed in 2006. You know, people say that the ACA was modeled after Massachusetts health reform. The ACA, if you've read my book, you know, it has 10 titles to the law, 10 chapters, 10 major portions. And Title I of the law is based on the conceptual model of Massachusetts. And that is absolutely true. The rest of the ACA has nothing to do with what was done in Massachusetts because Massachusetts was only doing access along the lines of what was accomplished in Title I. But nonetheless, Massachusetts set up the similar subsidy structure that we see established within the ACA that will start on January 1st. The Massachusetts subsidies are significantly more generous in terms of premium support and protections against excessive cost sharing than we see in the ACA. So much so that Massachusetts, when it had to pass a law adapting its health reform structure to the new ACA structure, decided to take some of the savings and use them to make sure that the affordability levels in Massachusetts reform would be maintained and not drop down to where they are under the ACA. I don't believe at this point that the ACA subsidies are truly cognizant of the real realities of folks, particularly at some of the lower income levels under 250% of poverty, or even above between 250 and 400% of poverty. And I believe that that's something that is very much going to have to be addressed. We know that enrollees from the experience of Massachusetts are driven to the low premium products. And you all know the ACA has the 4 metal bar levels of platinum, gold, silver, bronze. And it's no mystery what's behind it. Bronze means lower premiums and much higher cost sharing. And platinum and gold mean much higher premiums and much lower cost sharing. And we know overwhelmingly that the people will be going to the low premium products and not paying particularly close attention to the situation that they will be putting them in terms of cost sharing. And that is going to be a significant problem, and again, something that I think is going to have to be addressed. And then there's also the 2020 threat. And the way the ACA was written, and this was done deliberately at the last minute to try to achieve a favorable score from the Congressional Budget Office for savings beyond the first 10 years, because the 10-year budget window for the ACA was 2010 to 2019. And so beginning in 2020, there is a significant compression of the affordability standards within the ACA that, if left unimpeded, will create significant affordability hardships moving forward. Now, we are still a long way away from 2020, but not that far away. This is something that people need to be aware of. It is going to have to be addressed, or the less than ideal affordability standards will become unacceptable very quickly in terms of what real Americans will face. This one I said, the ACA's fiscal future is as uncertain as its affordability guarantees. And by that, I meant good news. And the reason I say it's good news is because one of the things that we know is that most of the financial projections are done by, of course, the nonpartisan Congressional Budget Office. While we were doing the health reform process, Karen Davis at the Commonwealth Fund had a wonderful inspiration, and that was to go back and see how well the Congressional Budget Office had done in prior major health reform efforts, because the CBO had been around since 1974. There had been big health laws that had passed since then, and no one seemed to have any idea when she would ask around how well CBO did. So she hired John Gable from Chicago to do the analysis. He came up with a report. He wrote an op-ed on the report that appeared in the New York Times on August 26, 2009. I remember it because it was the day that Senator Kennedy passed away. And his observation was quite compelling. He looked at the three major health reform episodes prior to the ACA. He looked at the creation of the prospective payment system, the DRG system for paying hospitals in 1983. He looked at the Balanced Budget Act in 1997, which achieved most of its budget reduction through dramatic cuts to Medicare. And he looked at the 2003 Medicare Modernization Act that created the Part D drug program. And it was very interesting. He found that in all three cases, when he looked at what actually happened versus what CBO projected, that CBO was wrong. And they were not wrong by a little, they were wrong by a country mile. And in each case, they were wrong in the same direction. They overestimated the costs, and they underestimated the savings and the revenues. Which, if you think about it, if they're going to be wrong, you'd probably rather them be wrong that way than the other way, because if they're wrong the other way, then you have an oh my God moment where you have to try to figure out how are we going to pay for these unexpected bills. And of course, if they're wrong in the direction they were, nobody cares. I mean, it's Miller time. Go out and have a beer, enjoy life because things are okay. And of course, it's only a set of three, so it has no statistical significance. But of course, if you think about the institutional imperatives on an entity like CBO, all of the pressures on them are to be as conservative as possible in their estimating so they avoid the alternative that people don't want to see. So the question is right now is, can we already draw some conclusions in terms of the ACA? Well, yes, we can. One of the dramatic changes that has happened, of which, by the way, Americans seem to be completely unaware of, is that we have seen a dramatic deceleration in the rate of health spending growth over the past 4 to 5 years, both public and private. Here's a chart that shows the growth in national health expenditures. You can see it is at an historic low. It's affecting Medicare and Medicaid. Medicare right now versus how much CBO expected Medicare to grow over the 10-year 2010 to 2019 period. In 2010, when the law was signed, is now $750 billion over 10 years, lower than what they projected. And Medicare's rate of growth is about 240 to 250. So it's more than $1 billion more than $1 trillion in unanticipated savings over a 10-year time window. And it's also affecting private sector. Some of this is clearly related to the economic downturn and the sluggish economy. And the conclusion of a wide array of experts is that it is not, that there's other things that are going on in the healthcare sector right now. There's a new report that came out the week before last from the White House Council of Economic Advisors. Healthcare price inflation is at its lowest rate in 50 years since we've been tracking it. By the way, this is one of my favorite charts. This is, by the way, the Commonwealth Fund does an excellent series on international comparisons, and I invite you to go look at it. They just updated their series within the past month. This is health spending as a percent of GDP. There's so much to talk about on this one chart, but I'll just mention a few things. We're, of course, the black line. If you go back to 1980, right, we're probably the most expensive in terms of how much of our national wealth we spend on health, on medical care, but we're very much in the pack. And it was really in the 1980s that we first broke loose, right? And then you go here and you see in the 1990s a flatlining right here. Some of this it was right in the wake of the failure of the Clinton health reform and the explosion in managed care. And we saw a significant drop in the rate of growth of healthcare spending. These last years, spending was starting to go up, but if you remember, this was the end of the 1990s, and it was a big economic boom. And of course, when we look at this measure, we look at both the numerator and the denominator. The numerator is healthcare spending. The denominator is overall economic growth. And growth was growing so quickly that it kind of masked an increase going on. But then you see, in the early part of the last decade, a shoot up again and a climb. And then what you see, and I've been waiting for this chart to come out because the last chart until a month ago cut off around 2007, so it cut off right here. And now what you can see we're back in flatlining. And if we carried this forward, this only goes through 2011. If we carried this forward through 2013, we're in another flatline period right here now. Now we know from this history, we can't count on it sticking that way forever, but it's a very significant period. It's a very significant trend. People derided President Obama for making a claim when he was a candidate that he would save Americans $2,500 on their health insurance policies over some period of time. If you actually look at the net savings over the past 5 years and the projections going forward for the next 5 years, actually Americans have probably saved more than $2,500 from the flatlining. Now, some of this, we believe, has significant connections to the ACA. Some of it does not. And it is, though, a significantly remarkable moment to be aware of and understanding that if we let down our guard, it doesn't last. It won't stay. It doesn't stay by accident. Next, something that is not talked about much. There are two things the White House doesn't seem to like to talk about a lot. The White House doesn't like to talk about Medicaid. They are significantly reticent in noting that since October 1st, we have seen the most significant signups coming on the Medicaid side of the health expansion ledger, even in states like South Carolina that are not expanding Medicaid. People who are eligible and unenrolled are now coming out of the woodwork because of all of the attention to getting coverage. So they don't like that, and they don't seem to like to talk a lot about the reality that, that racial and ethnic minorities, non-whites, are going to be significantly advantaged by the full implementation of the Affordable Care Act. More than half of the nation's uninsured are non-white. Congressman Jim Clyburn from South Carolina calls the ACA the Civil Rights Act of the 21st century. It's a significant achievement, and that's not all. That's not all. Folks in the mental health community consider the ACA to be one of the most significant advances in mental health policy ever through American history, through the elimination of pre-existing condition exclusions in medical underwriting, through the ending of annual and lifetime benefit caps, through minimum essential health benefits, which specifically mentions mental health as one of the required benefits. This is a significant revolution for mental health and for the mentally ill. Similarly with women's health, the National Partnership for Women and Families calls it the greatest advance for women's health in a generation. Similarly, the addiction substance abuse community. This is the White House former Deputy Director for Drug Policy. He said, I don't think there's another illness that will be more affected by the ACA than addiction. And also, finally, disability. The disability community changes the paradigm for working age adults with disability. So when I wrote my book, I only included racial and ethnic disparities. And looking back, I realized that this is a landmark for so much more than just than racial and ethnic disparities in care, in health and healthcare. Finally, it's my last one. This will be the most. This is what I said. This will be the most challenging implementation of a federal law since civil rights. I think that's pretty true. By my count, the ACA has had 3 near-death experiences. The first came before it was signed into law with the election of Scott Brown to Senator Kennedy's seat in Massachusetts when Democrats lost the 60-seat filibuster-proof majority, and many people said there's absolutely no way that it can become law now, health reform is dead, and they were wrong. The second near-death experience was the Supreme Court consideration of the Affordable Care Act. You may recall the oral arguments in March of 2012. Several days later, the justices got together in their chamber, had an introductory discussion, and took a straw poll, as they always do, to figure out where people stood. And at their first straw poll, there were 5 votes of the 9 justices to repeal the entire law. And there were 4 votes not to. And then Chief Justice John Roberts, in the subsequent weeks and months, had a change of mind, a change of heart, a change of something that switched him from being against total repeal only to the changes in Medicaid. That was a near-death experience. And then the November 2012 federal elections certainly could have been a near-death experience had Mitt Romney been elected president and brought with him continued control of the House and Republican control of the Senate. The ACA, most of it would be already repealed by now. I absolutely believe that. We were surprised, when I was working in the United States Senate on the Senate Help Committee, they gave us a TV on our desk so we could always kind of watch what was going on the floor. And then when they're not in session, you couldn't help it. You'd turn on CNN or something, or Fox, or just to see what was being discussed. And we saw endless advertisements from the United States Chamber of Commerce talking about how health reform is going to be the death of small business, the harm it was going to do to small business in the United States. It wasn't until well after a year after the law that we learned that almost that entire campaign, $120 million worth, was funded in toto by the health insurance industry, by the major health insurance companies, standing up for small business. We've also, since the signing of the law, we have seen a continuing war on the credibility of the ACA. I got invited to a group that meets up in Lynn, Massachusetts. It's a group of retirees from the General Electric plant that used to be it's still there, but it's much smaller now. And they call themselves the GE Old Timers Association. They're retired engineers and managers. And they invited me up to talk about the ACA, and they decided they really liked me, so they keep inviting me back. And they started sending me these emails that they were getting. And they said, can you explain to us what the heck this email is? Because they were all getting bombarded with emails, all of them. I don't know how the people got their email address, informing them that in January 2013, after President Obama had been reelected, that their Medicare Part B premiums would quadruple, and that it was written into the ACA, but they were keeping it hidden and secret so that people would not get angry. And this email is coming out telling you the truth. Totally false. Totally false. One of the messages that came, I looked through the message trail and I saw that it came from a woman who worked for Blue Cross Blue Shield of Alabama. And so I said, well, this is interesting. So I called up, and it had her phone number. So I called up. The number had been disconnected. So I called up the PR people for Alabama Blue Cross and Blue Shield to say, hey, what's going on? And they said, this woman heard this information. She wouldn't disclose where, and she made a mistake in putting it out on an email address associated with Alabama Blue Cross. She had been dismissed from the company, and the company was now doing training with all of its employees to make sure that no one would similarly abuse their email privileges. But we saw literally hundreds of examples of this. And we have no idea where these came from, except that we know that there is substantial funding going on to try to undermine Americans' confidence, which leads to the politics of public opinion on this law and how difficult that has been. Perhaps the highlight for me, I don't know how many of you saw it, was on the Jimmy Kimmel show a couple of months ago, where Jimmy Kimmel went out and interviewed people on the street. I think it was in Los Angeles. And he asked people, he said, so tell me please, which do you prefer better? Do you prefer the Affordable Care Act or do you prefer Obamacare? And all of the people, with one exception, it was the African-American guy who said he preferred Obamacare. But everybody else said, no, we hate Obamacare, but we like the Affordable Care Act. Completely unaware that they are one and the same thing. I don't know. And then there was another poll from Kaiser about 6 months ago that showed that about 42% of Americans believed that the ACA had already been repealed. So I don't know how you judge public opinion when there is that level of mass misinformation about it. And then we have the endless media hyperventilation. Every disturbance on the road to implementation, first to passage and then to implementation of the law, becomes an excuse for extraordinarily heavy breathing about how now they're in big trouble. I have sort of probably like with Jim Talon. I mean, I've been involved in health reform since 1985 when I got elected to the Massachusetts House. My observation is that the road to health reform it's kind of like, imagine you're barreling down a mountain in say a poor impoverished country without adequate roads. You're barreling down a dirt road of a mountain in a crowded bus with no guardrails and lots of potholes at breakneck speed. And you constantly are this close to falling off the edge into the abyss. And of course, we know that's not hypothetical. The Clinton health reform bus fell off the road. The California health reform bus fell off the road. We know it can happen. It is just especially difficult when somebody did a satire of if the DC political paper Politico had been around when Lincoln was trying to fight the Civil War, and the Daily, oh my, he's really blown it now. How will he get out of this mess? And it's sort of on, because you can construct that scenario, but that is part of it. And then of course there are obviously our self-inflicted wounds around the website, which I don't have a rational explanation for more than any of you. I will just say, I'll conclude with this. I do believe that right now there is nothing that is standing in the way between us and January 1st. I think that we are just about there. And we will still have disruptions. We will still have disappointments. We will still have controversies. This will still be a contentious issue, probably through at least the 2014 midterm elections. But I do believe that after January 1st, fundamentally, there's no turning back. We are not going to go back to an environment where insurance companies, as a normal business practice, discriminate against Americans because of their prior medical history. We are not going to withdraw the subsidies that Americans are now getting to help them pay for health insurance. We're not going to take the Medicaid coverage away from the states that have duly adopted the expansion. These are not going to go away. And so I think we are on, in spite of all of the consternation, in spite of all of the distress, we are on the threshold of a brand new day in the US healthcare system. And we've been working on this day for a long, long time. So many of you in this room, so many across the country. And so I hope that my words can provide somewhat of a calming influence on those of you who are perhaps unduly distressed by what you see on a day-to-day basis. We've been going through this for a long time. This too shall pass. And we are entering a whole new era in US health reform, which I think is going to lead us to a much better and juster healthcare system for all Americans. So thank you.